Good afternoon, everyone. So today's topic of my presentation is going to be on military and disaster psychiatry. Hi, I'm Dr. Akash Chaudhary, junior resident in Psychiatric Department, Subhati Medical College. Our today's focus will be firstly on military psychiatry, which includes introduction, prevalence, causes, symptoms, prevention, followed by disaster psychiatry, which comprises of disaster response pattern, resilience, role of mental health professionals, and finally the conclusion. Military psychiatry. Military psychiatry is a specialized branch of psychiatry that focuses on the mental health issues and psychological well-being of military personnel, veterans, and their families. It involves the diagnosis, treatment, and prevention of mental health disorders that may arise due to military service or other related factors. So we are going to discuss both the military aspect and what the family or the close by of the and the family members and the friends that the patient goes through and what they actually go through while serving in the military. How prevalent is mental illness among armed forces? Prevalence of psychiatric disorder in military population comprises of post-traumatic stress disorder, which is from 12 to 20%, and depression found 3% to 15%. Causes of mental illness. Combat-related traumatic events, which comprises of being under fire, attacked by civilians or insurgents, engaging in battle, injury in battle, killing others in the battle. Post-battle traumatic events comprises of seeing soldiers wounded or dead, seeing civilians wounded or dead. Civilian stresses, which comprises of divorce or breakup, losing job, stressful legal problems, lack of adequate healthcare, and financial problems. First, combat stress. Used to describe a set of symptoms. These are expected, predictable, emotional, intellectual, physical, or behavioral reactions of service members who have been exposed to stressful events in combat or military operations other than war. What type of mental illness are expected? A focus on common psychiatric disorders. Bulk of studies focus on post-traumatic stress disorders. Other disorders include depression, substance abuse disorders, in particular alcohol abuse, and dependence. ICD-10 and criteria for post-traumatic stress disorder. It comprises of A, exposure to a stressful event or situation, either short or long lasting, of exceptionally threatening or catastrophic nature, which is likely to cause pervasive distress in almost anyone. Persistent remembering or reliving the stressor by intrusive flashbacks, vivid memories, recurring dreams, or by experiencing distress when exposed to circumstances resembling or associated with the stressor. Actual or preferred avoidance of circumstances resembling or associated with stressor not present before exposure to the stressor. Now, option D consists of 1 and 2 subcategories. In subcategory 1, it is the inability to recall either partially or completely some important aspects of the period of exposure to the stressor. Second, persistent symptoms of increased psychological sensitivity and arousal. So point A to E are the points which comprises of what it basically causes increased awareness in the patient who's going through PTSD or post-traumatic stress disorder. Post-traumatic stress disorder is just not limited to military psychiatry. It can also be found in people who are sexually abused in their younger childhood and they want to forget the event completely and altogether, so they are not able to recall those moments or incidents happened during that part of life. The arousal symptom consists of difficulty in falling or staying asleep, irritability or outburst of anger, difficulty in concentrating, hypervigilance, and exaggerated startle response. Now, difference between acute stress disorder versus post-traumatic stress disorder. First, acute stress disorder, its onset is 0 to 28 days after the trauma has occurred. The duration lasts between 3 days and 4 weeks. Symptoms may comprise of depersonalization and derealization. Treatment comprises of short-term psychotherapy and antidepressant medications. As compared to post-traumatic stress disorder, at least 1 month after the trauma has already occurred. Lasts for at least 1 month and can persist for several years. Symptoms comprises of avoidance, heightened awareness, and changes in mood or cognition. Long-term psychotherapy, medication, and eye movement DR therapy, which has been further explained in the upcoming slides. Symptoms according to the time. So there can be different representation of the symptomatology patient going through post-traumatic stress disorder. Initially, the symptoms might be at a very high range or at a very low range. Then as the time passes by on the y-axis, the symptomatology of the patient may go haywire to in the y-axis, or after a period of time they adapt to the situations, or it may persist after 90 days as well. A trivia known as a 1,000-yard stare. The 1,000-yard stare is a phrase often used to describe the blank, unfocused gaze of people experiencing dissociation due to acute stress or traumatic events. It was originally used in reference to war combats and the post-traumatic stress they exhibited. So this has come like it has become quite popular in current popular culture. It has been being observed in the basically the street rappers who rap in the New York cities. People living in Bronx or in cities, whenever they have gone through a pretty traumatic childhood, they have seen a lot of murders throughout their life. So what the psychiatrists have been observing is that they develop this constant gazing toward the psychiatry, which comprises of 1,000-yard stare. It was first observed in World War II, in which after coming from the battle experiences, they would see that they used to stare blankly in front to the doctor as if they are staring somebody quite afar. How do we address mental health after conflict? We can tackle it by preventing it and treatment. First, prevention and resilience. Military psychiatrists work to prevent mental health problems by promoting resilience and providing training in coping strategies and stress management techniques. They may also be involved in pre-deployment screenings and assessment to identify individuals who may be at a higher risk for mental health issues during deployment. Prevention. A rapid and contextually grounded assessment of salient stressors is needed before developing interventions. Possible methods include focus group, free listing, and key informant interviews. One which is quite interesting is free listing. In this, what they did was they basically called out all the members who went through the war, and they were asked what events did they specifically go through and which were the most stressful events that they experienced. After which the psychiatrist concluded a list so that they could preempt, like whenever the next case of post-traumatic stress disorder comes by, so they know how to deal with their problems. So this is what free listing is all about. We can apply this same incidence regarding any other disaster which can occur throughout the society which is currently going on, that what can we expect after a veteran or a military personnel comes for these kinds of problems. So we already would be having a list. How should we tackle those issues? First, address the combat-related civilian stresses before providing clinical services that target mental health. When clinical services are indicated, service should target a broad range of mental health condition and not only PTSD. It is also imperative to take into account that the symptomatology seen may not be solely due to conflict exposure. There may be other sources of psychological trauma. Diagnosis and treatment. Military psychiatrists diagnose and treat a wide range of mental health disorders, including PTSD, depression, anxiety, substance abuse, and adjustment disorders. Treatment approaches may include therapy such as cognitive behavioral therapy or exposure therapy, medication management, and other intervention tailored to the unique needs of military personnel. Specialized services, narrative exposure therapy showed beneficial effects on PTSD. Same as enlisting, the person is asked to narrate the story what he went through, and are asked that they have to narrate in the same way that they experienced it, which also help to overcome the repressed emotions that they are going through. Focus therapy, psychoeducation, group-based trauma, and grief-focused testimony therapy. Now this eye movement desensitization and reprocessing. Therapy is a mental health treatment technique. This method involves moving your eyes in a specific way while you process traumatic memories. EMDR's goal is to help you heal from trauma or other distressing life experiences. Reintegration and rehabilitation. Military psychiatrists play a crucial role in helping service members reintegrate into civilian life and deployment and supporting veterans in their transition back to civilian life. This may involve addressing psychological challenges related to reintegration, providing support for the family members, and connecting individuals with resources and services in their communities. Research and training. Military psychiatrists involves ongoing research to better understand the psychological effects of military service and to develop more effective prevention and treatment strategies. Military psychiatrists also provide training and education to other healthcare professionals, military leaders, and the broader community on mental health issues relevant to military population. In conclusion, overall military psychiatry is a critical component of ensuring the overall well-being and readiness of military personnel and veterans. addressing the unique mental health challenges they may face as a result of their service to their country. Now comes disaster psychiatry. This topic is particularly in relevance as what disaster is not just limited to basically earthquakes or floods in which there's lives of human. It can also be related to any, like a disaster can also be concluded as a COVID epidemic that just went by. It's just not related to that there should be a specific earthquake or a huge calamity and there should be loss of life. A disaster psychiatric also comprises of like the basic human emotion that somebody goes through if there is fall in the stock market. There's a rapid increase in the complaints of depression and the trauma, and there's increase in suicide rates as well. That also falls under the disaster psychiatry and how we are supposed to deal with it. First, it comprises of introduction, disaster response pattern, resilience, role of mental health professional, and then finally the conclusion. What is a disaster? A disaster is an occurrence that causes human suffering or creates human needs that the victim cannot alleviate without assistance. What is critical incident? A natural or man-made event or situation that has the potential to temporarily overwhelm the ability to maintain psychosocial equilibrium. Traumatic events comprises of natural disasters, disasters of human intention, other interpersonal violence, and sudden traumatic loss. Consequences of disasters. Physical, which comprises of destruction, injury, and death. Mental health, various forms of stress are common. More mental health injuries than physical injuries. Mental health or community before disaster will determine how resilient after disaster we are. Disaster mental health services are vital component of planning and response. Now this basically is a pie diagram of how what are the, it's basically like a iceberg phenomenon. Like the tip of the iceberg, that the medical footprint is way too small as compared to the psychological footprint that somebody goes through after a disaster. In a disaster, the size of the psychological footprint greatly exceeds the size of the medical footprint. Frequent needs after emergency. Basic needs consists of shelter, food, water, and sanitation. Health services for injuries or help the chronic condition. Information on what was happened, services available, information about the family. Contact with their families, being able to connect to their own religion and culture, and being involved in important decisions. Disaster psychiatry is a specialized field with psychiatry that focuses on the psychological impact of disasters and mass traumatic events on individuals, communities, and societies. It involves the assessment, treatment, and prevention of mental health issues that arise in the aftermath of disasters such as natural, which comprises of hurricanes, earthquakes, floods, etc. Human-made disaster, example terrorist attacks, mass shooting, industrial accidents, and public health emergencies, example pandemics that we have all been witness to recently, COVID-19. What you in the further slides will also explain what actually happened and how we can preempt. You will be very easily able to correlate with yourself with from the upcoming slides. That's actually how event unfolded. So we can basically through these, the science and psychology have gone so far off that they are already preempting the behavior that the humans might be going through. So first there's a disaster and there's heightened emotion of the population. In the first week, this is called as heroic phase, in which all the donations comes around from all over the world and everybody is trying to help each other. It lasts for 2 to 8 weeks, also known as honeymoon phase, in which there are no shortage of funds. Everybody is quite, the wounds are quite fresh, both physically and mentally, and everybody is trying to help each other out. Then after some time, there's this disillusionment phase, in which there's some fatigue developed within the crowd, in which the patient, then the funds also start waning off. The health support also starts diminishing as the time passes by, and people are not that much motivated to help each other. This had happened that what we also faced during the COVID-19, that we made a special work group known as Asha, in which we helped people in Delhi all around, people living in shelters, people living under flyovers. So at the first wave, we were all quite determined that we have to help everybody. The number of donation that we got was phenomenal. Even people from Coca-Cola industry approached us. They said that we want an interview with you guys, the amount of phenomenal work that you guys are doing. And by the time the second wave came by, so the self-help groups were reduced drastically in number, and they insisted us that you should again you should again resume your work. But the members of the team also were like, we are done. So at the end, only 2 or 3 people were left. in this disillusionment phase comprises of the maximum amount of psychiatric illnesses that people suffer. The stars marked in this graph are the basically the duration. Initially, when there is shortage of funds, then these psychiatric symptoms are more overt, and then eventually, as time passes by for 2 to 36 months, these symptoms again come on, are more florid. Typical disaster response pattern, distractible in cognition. So basically, this is what a human being goes through, what all declines that somebody fails. In cognition, there's distractibility, declining schoolwork performances, recurrent intrusive recollections, flashbacks, and nightmares. Behavioral, there's clinging isolation, thrill-seeking behaviors, reenactment of the trauma, increased substance abuse, hypervigilance, elevated startle reflex. Physical, shock symptoms, insomnia, loss of appetite, headache, muscle weakness, and elevated vital signs. Affective symptom comprises of depression, anxiety, numbness, constricted affect, guilt, shame or fear, intolerance of fear response, and global pessimism. The affective symptom mostly of a guilt, shame, and fear. What could they have done at that time? What they would have, what were the right choices that they would have gone through? Everybody in the present retrospects, what were all good decisions they would have taken, and that forms another cycle of constantly overthinking regarding the disaster. This is like one of the worst phases: guilt, shame, and fear. Potential reaction to sudden violent events. Basically, it comprises of a summary of what there's physical, emotional, cognitive, behavioral, and spiritual events that somebody goes through after going through a disaster. Resistance, resilience, and recovery. Resistance. Defend against manifestation of distress, impairment, or dysfunction. Resilience. Rebound rapidly and effectively from psychological distress. And recovery. Regain the ability to function adaptively in the wake of distress, impairment, or dysfunction. Healthy coping skills. Ability to orient oneself rapidly. Planning and execution of decisive actions. Appropriate use of assistance resources, tolerance of uncertainty without restoring to impulsive actions, appropriate expression of painful emotions. This takes a lot of practice, and tolerance of uncertainty will eventually develop when everything is so uncertain. So one should be always prepared for the unknown. Unhealthy coping skills comprise of excessive denial and avoidance, impulsive behavior, over dependence, emotional suppression, and substance abuse. Cultural factors influence disaster reaction and coping skills. National origin, customs and traditions, length of residency, language, age and generation, gender, religious and political beliefs. The difficulties that once we'll face once we go out in the society, and to bringing everybody into a common minimum program is a very tough job to do. Perception of family and community, healthy well-being, disability, socioeconomic statuses, education levels, and geographic locations are multiple varied factors that depends on how we're supposed to act after a disaster has occurred. Role of mental health professionals. Wherever possible, before you enter a crisis site, try to learn about these things. The crisis event, what happened, where it happened, when it happened, and how many and who are affected. Then we should always look for the available services. Who is providing for basic needs such as emergency, food, and shelter? When and where can people access services? Who is helping, including community members? Before going to a disaster site, these are the basic points that we should keep in mind. This will have a solid plan that how we're supposed to deal with the current situation. Safety and security. In this, the crisis is over of ongoing aftershock and fighting. What dangers may be in the environment? Are these places to avoid due to insecurity or because it is not permitted to be there? Immediate response and crisis intervention. In the immediate aftermath of a disaster, disaster psychiatrists and mental health professionals may provide crisis intervention services to individuals who have been directly affected by the event. This can include psychological first aid, emotional support, and assistance in coping with acute stress reactions. Psychological first aid, a set of skills that helps community residents care for their families, friends, neighbors, and themselves by providing basic psychological support in the aftermath of a traumatic event. PFA actions principles. Prepare consists of 3 L's. First, we prepare, learn about the crisis event, learn about available services and supports, learn about safety and security concerns, then look. Observe for safety, observe for people with obvious urgent basic needs, observe for people with serious distress reactions. It's like a triage on our own. Whenever we are going to a disaster site, that's how we are supposed to manage who needs the most attention first, and comparatively to our, it all depends on our judgment. Then listen, make contact with people who may need support, ask about people needs and concerns, listen to people and help them feel calm, then link them with each other, help people address basic needs and access services, help people cope with problems, give information, connect people with loved ones and social support. Assessment and triage. Assess the mental health needs of individuals and communities affected by disasters, triaging individuals based on the severity of the symptoms and level of distress. Identify individuals at risk for developing post-traumatic stress disorder, depression, anxiety disorders, substance abuse, and other mental health issues. Treatment and support services. Provide evidence-based treatment for trauma-related disorders and other mental health conditions, including psychotherapy, medications, and supportive interventions. Coordinate with other healthcare professionals, emergency responders, and community organizations to ensure that individuals receive comprehensive care and support. Pharmacological interventions. First, the target symptoms such as insomnia. We can give them zolpidem, ramiltion, trazodone, and anxiety, benzodiazepines, clonazepam, propranolol for acute symptoms, and depression. Then SSRIs are the first line choice. Community resilience and psychosocial support. Work to promote resilience and psychological well-being at the community level, facilitating the development of support networks, community-based mental health services, and disaster preparedness initiatives. Collaborate with local authorities, non-governmental organizations, and community leaders to address psychological needs and promote recovery and healing in the aftermath of a disaster. Promote resilience. Everyone who experiences a disaster is touched by it. We have the ability to bounce back after a disaster to a new normal. Resilience can be fostered. Basically, it's a skill that can be honed. First, we have to teach the people how they can be resilient and how they're supposed to bounce back from whatever stressor they are going throughout their lives. One goal of psychological first aid consists of support resilience in ourselves and in others. Positive coping strategies, according to culture, help people use their natural coping mechanisms to regain a sense of control, get enough rest, eat as regularly as possible, talk and spend time with family and friends, relax, walk, sing, pray, play, and children, exercise, avoid alcohol or drugs, bathe and attend to personal hygiene, find safe ways to help each other. Give information, find accurate information before helping. Keep them updated so you develop a trust with the people who are getting suffered. Make sure people are informed when and how to access services, especially vulnerable people. Say only what you know, don't make up information. Because this may lead up to that they stop trusting you if they get the information correct from other sources. Keep messages simple and accurate and repeat more often. Give the same info to groups to decrease rumors. Explain sources and reliability of your info that you give to the sufferers. Let them know when, where, and when will you update them again. Social support is very important for recovery. Keep families together and children with caregivers. Help people contact friends and loved ones. Give access to religious support. Affected people may be able to help each other, bring them together. Make sure people know about how to access services, especially the vulnerable people. Then, when you are about to end your assistance, the things, the final goodbyes that we are giving to the persons who are suffering from it. Use your best judgment of a person's needs and your own needs. Explain you are leaving, and if possible, introduce them to someone else who can help. If you link them with the services, be sure they have contact details and know what to expect. No matter what your experience, say goodbye in a good way. Wish them well. Now, research and education. Disaster psychiatry involves ongoing research to better understand the psychological effects of disasters, identify risk and protective factors, and develop effective interventions for mitigating the impact of traumatic events. Mental health professionals in the field also provide education and training to healthcare providers, emergency responders, and community members on topics related to disaster preparedness, trauma-informed care, and psychological resilience. In conclusion, overall, the disaster psychiatry plays a critical role in responding to the mental health needs of individuals and communities affected by disasters, promoting recovery and resilience, and contributing to the broader field of disaster response and emergency management. These are my references.